So Clostridium species. So the question was actually about pseudomembranous colitis, but I always get confused between the different Clostridial species. So as a really quick review, there are 4 types of Clostridial species: Clostridium tetani, the one Clostridium botulinum, Clostridium perfringens, and Clostridium difficile. So the Clostridium tetani causes that spasms, muscle spasms. Clostridium botulinum is the one that causes flaccid paralysis. Clostridium perfringens causes the bloody diarrheas. And Clostridium difficile is an antibiotic-associated diarrhea with pseudomembranous colitis. So in pseudomembranous colitis, so it's all antibiotic associated. So what are the antibiotics that cause this? So antibiotics are one of the causes. Also an increasing age, being in the hospital environment a lot with the nosocomial infections causes it, and of course the antibiotics. So the antibiotics that you need to worry about are clindamycin, cephalosporins, fluoroquinolones, ampicillin, and PPIs, omeprazole, and so forth. So typically, some of the ways they ask you questions are, you avoid these antibiotics to prevent it. So what antibiotics should you take to avoid it that have a low risk associated with pseudomembranous colitis? So that would be macrolides, aminoglycosides, tetracyclines, and trimethoprim sulfamethoxazole. So those are some options that have lower risk. So that's one way a question can come up. Now, whenever you look at pseudomembranous colitis, they're going to present with symptoms of diarrhea, fever, abdominal cramps, and so forth. So you look at, is this mild or moderate, or is it severe? So that's based on, like, if your WBCs are more than 15,000 and your creatinine level is more than 1.5, then it's considered severe. If it's severe, it does have complications like toxic megacolon and ileus. So you would manage them accordingly, which might involve getting IV metronidazole or surgeries and all the supportive care that goes with it. Now, with pseudomembranous colitis specifically, another way a question has come up is, how do you actually diagnose it? So it's not, I thought it was pretty simple that if you had these risk factors of using antibiotics or something, or having been hospitalized with having risk for nosocomial infections and stuff, that you would automatically get it. But no, the actual diagnosis requires 2 things. One is you need to have 3 or more stools in a 24-hour period. And the second thing is the stool should be positive for Clostridium difficile, whether it's the PCR or you're doing the antigen testing in the stool. So both of those need to be there. Now, if you look at the microscopy, they'll give you something like the superficial colonic necrosis with overlying pseudomembranes. The pseudomembranes are like these mushroom shaped, and they have all these inflammatory exudates, the cells, the mucin, all the cellular debris and stuff. Now, one of the questions they're asking is, a person comes in with, was admitted to the hospital for some infection, and they were on antibiotics, whether it's a UTI or whatever it is, they were on the antibiotics that are responsible for pseudomembranous colitis, and they get treated, and they go home, and after a couple of days or so, they start having symptoms again of diarrhea. So unless they specifically say it's 3 or more stools in a 24-hour period with a positive stool antigen, it is not C. difficile. So that's where the confusion lies. So now, once you're treated for C. difficile, what happens if you get, you're treated with actually vancomycin or fidaxomicin. And if you get it again the second time, you go back to these antibiotics. You can switch them around depending on which one you used, but it's essentially the same 2 antibiotics, the vancomycin and fidaxomicin. Now, if this happens multiple times, repeatedly, the infections, it's still vancomycin, PO, and you follow it with rifaximin. And If you are just refractory to everything, it's a fecal transplant. So that's it. Hope that helps. That's where all the questions come from.